off my mic. I'm going to turn.
Beneficiaries can access care in Plumas County. This is recorded. I do plan on putting it on the website and sharing with anybody that requests it. And if you have follow-up questions, you can reach out to me here at the department, and I'll get my contact information later. So let's see here. Today's purpose of the training will focus on the following topics and how changes to these topics under CalAIM will impact your access and care through Plumas County Behavioral Health. So we're going to talk about the new definition of medical necessity, adult and youth eligibility criteria for accessing specialty mental health services, clarifying no wrong door, and moving to the problem list, and then no more treatment plans through our services. So the first thing we're going to talk about is access to specialty mental health criteria versus medical necessity. A lot of times these two things are blended together and kind of interchangeable when in fact they're very different. So the first one is access to specialty mental health services, which refers to an individual's eligibility for specialty mental health care. And there is different criteria for adults versus youth, and we'll get into those in a minute. And then there's medical necessity. It determines what services are appropriate for the client and if the client requires the level of care provided through PCBH or if they would be better served with a mild to moderate provider or maybe their primary care. So access is what gets you in the door, and then medical necessity is what determines what kind of services you would benefit from. And there's many different services that we offer and many different services that mild to moderate providers offer, and they are different. So it's important to remember that Plumas County Behavioral Health is specialty mental health services, which means we are moderate to severe, and our target population are those that are a step below a psychiatric hospital placement. So we want to make sure that we stabilize and bring down and prevent an increase in care or hospitalization. A lot of our services are targeted at stabilization and then connecting to a lower level of care, which is what we refer to as mild to moderate. And that's usually through your managed care plan or your health insurance network or your primary care. There's a handful of private providers in the community that do contract with managed care providers. And so those are also options of care. And we'll talk about more of that as we go along. So access criteria gets the individual in the door to receive specialty mental health. And then medical necessity determines what types of level of service the client could receive. So what does this mean for actual practice? It means improved coordination with other systems and counties. California has embarked on this CalAIM mission, which is like a giant tree. I like to describe it. It's a tree with many branches, and one of the branches is specialty mental health, and then there's other branches that involve other systems of care. Mild to moderate providers, even primary care providers, even dental facilities will be affected by CalAIM and how we work and share information together. So California has said we need to be more streamlined and be on the same page, and this will improve coordination, it will improve quality of care for clients, and it will reduce access barriers. So they've developed a new standardized screening tool and a transition tool, and it is standardized across all of the counties in California. So we will all be using the same tool at the same time, and that way everything's the same everywhere you go. This will be, I'm going to show you here in a moment, we have a screening tool here to determine level of care. It separates those who are mild to moderate versus SMI. We are piloting those screeners now. However, there is a final version set to be released by the state in 2023. So these tools might experience some minor changes as we go along. The same tools will be used at all access points, regardless of if it is through PCBH directly or one of our contracted providers, such as the school district. This is the beginning of our adult screening tool. It goes through instructions on how to utilize this tool. It's mostly for staff, but it is non-proprietary, so everybody can see it, and they're very basic directions. So it's great to just review and look at it. But basically, it's a series of yes/no questions that ends with a score at the end. And anybody who's 0 to 5 would be more appropriate for a mild to moderate provider. And anybody that is 6 and up would be more appropriate with a specialty mental health provider such as PCBH. We have not said that this tool is hard and fast rule for us. We are using it as a screening tool. However, beneficiaries are informed that they do have the right to request a full assessment if they so would like one. And so this is just kind of a guide for us to get it started. And historically, PCBH, the last couple, I would say probably 4 years now, we've operated access at an open access model or a walk-in clinic where beneficiaries could walk into one of our access points. We have an access clinic almost every single day of the week. On Monday and Wednesdays, it's in Quincy at the Annex. On Thursdays, it's in Portola, and Fridays, it's in Chester. And from 8 to 11, people can walk in, they can seek a mental health assessment and get a medical necessity, determine level of care. And that process used to take 2 to 3 hours. With the changes through AIM, we've implemented this screening tool. And instead of the full assessment and that 3 hours of service delivery, you would come in, answer this brief questionnaire, and get an immediate level of care recommendation, and then later called and provided an appointment with a clinician for the full assessment if you met that criteria. So if I was an adult and I was coming into one of my access clinics, I would say, hey, I'm looking for mental health services. I'm not really sure, where the best fit would be. And I'm Medi-Cal and I'm here today. And so then my case manager would sit down, we would do some opening paperwork with you and then go through this screener. And number one, is this an emergency or crisis situation? If yes, we don't finish the screener. We end it and we go to our emergency protocols. Can you tell me about why you're seeking mental health services today? It's just a brief statement about what brings you into care. It kind of helps us gauge the severity and what's going on for you. And then, are you currently receiving mental health treatment? If someone is receiving mental health treatment from another provider, that prevents us from onboarding services. We need to end this and get connected to your current provider to find out what kind of treatment they're currently giving you and if it's working. Because we don't want to duplicate services. We can't be treating you for the same condition that somebody else is treating you because our treatment meaning might be a little bit different. And so we would end there and get an ROI for that other provider or a release of information so that we could talk to them and gauge where services are at and if we can support those services instead of just saying no, goodbye. So if you're not receiving care, we would move forward. Have you sought help before today for mental health needs? Are you taking any prescription mental health medications? Have you tried prescription mental health medications in the past? Are you without housing or a safe space to sleep? Are you having difficulties in important areas of your life, such as school, work, relationships, or housing, because of how you are feeling or due to a mental health concern? Have you had any changes or challenges with the area of your life, such as personal hygiene, sleep, energy level, appetite or weight, sexual activity, concentration, or motivation? Have you completely withdrawn from almost or all of your relationships, such as family or friends? And have you sought emergency treatment for emotional distress in the past? You'll notice that some of these questions, most of them are 1, but 10 here has a score of 2 that could be received. And that's just a weighted score on how the state feels this answer would affect you or the level of care that you should receive. We go on to a few more questions. Have you ever been admitted to a psychiatric hospital? If you have you had more than one hospitalization? If yes, was your last hospitalization within the last 6 months? In the past month, have you had thoughts about ending your life, wished you were dead, or wished you could go to sleep and not wake up? Have you recently engaged in any self-harming behaviors like cutting or hurting yourself? Are you concerned about your current level of alcohol or drug use? And has alcohol or any other drug or medication caused you to behave in a way that is dangerous to yourself or others? Those last 2 questions have a score of 0, and it's not to say that they're unimportant. They just don't affect criteria for specialty mental health services. They are placed there and designed to be utilized as a screening function so that we can identify those who might benefit from our substance use program, which is slightly different than our mental health program, and so we have to screen those in separately. But you can see there is a total score that is given at the end of this process, and it does allude to if you're 0 to 5, we say, hey, it looks like you are more mild to moderate. We would like to connect you with your managed care plan. Let's get a release of information going. Let's see if we can call the number on the back of your card and find out how long the wait list is or what providers are in our area, and then we'll get you linked up to care. If the score is 6 or above, that means that's with one of my county providers here or specialty mental health providers if I had a contracted provider doing that. And then we would schedule you for the full assessment. Before, people would come into our access clinic, they would see the clinician of the day or whoever was on duty for that access clinic. They would go through the screeners, they would go through the full assessment, and at the very end, they would be told, it looks like you do qualify for care. Let's get you a different provider and get you signed up. So you could see maybe Keegan at Access and then get transferred to James and have to start over. The other thing that would happen is that you would go through the full assessment process, spend 3 hours in my clinic to be told, you don't meet our level of care. You're more mild to moderate, and we think you should call your insurance. And then we would cut you loose and let you go do that, which was very distressing for a lot of people and for myself. Nobody ever wants to be denied care when they want it, especially when it's a big deal for you. So we always want to make sure that there's care available, but we also have to honor the fact that we are a specialty mental health provider with limited providers. And so we have to kind of use these tools and screen people to their appropriate levels of care. But now through AIM, the difference is that we can hold you and provide services until you are connected to that level of care. So if you don't meet our level of care during the screening process or after the full assessment, we could offer to provide brief intermittent services until we get a provider on board who says, yes, I am serving this person. They are my client now. You can let go. The other thing through AIM that we'll get into more later is that we can actually straddle service deliveries. So you can have a mild to moderate provider and still receive some of our services and care. And then we can just work together as a family. But we'll get more into that as we go. So back to the level of care tool. We do also have a youth screening tool, which is slightly different than our adult screening tool. The youth is a little bit different in the fact that it's obviously a different set of questions, but we also have one where the youth is here and present. They're over the age of 12 and they're able to answer these questions themselves. Or we have another tool that's very similar that is designed for adults responding on behalf of the youth. So maybe my youth is only 11 or 10, or maybe my youth is not able to attend the screener today. So we can go over those questions with the adult or the person that's caretaking for that child. And so we can see here that there's a few more directions than the adult tool. And I will go ahead and at the end of this presentation post these slides so that you can refer back to them later. But I also have all these documents in PDF form that I can share with you if you would like. So we won't go word by word for the directions, but you can see here, is this an emergency situation? We always want to screen for emergencies. And then, we talk about, why are you coming in today? Are you calling on yourself on behalf of yourself or someone else? That way we can establish who we are speaking to. And then, are you in foster care or receiving child welfare services? Are you currently in juvenile hall, on probation, or under court supervision? Do you have housing or a safe place to sleep? Are you having thoughts, feelings, or behaviors that make it hard for you at home, school, or work? Are you having thoughts, feelings, or behaviors that make it hard to be with your friends or to have fun? Are you often absent from school, work, activities due to not feeling well? Is the person who takes care of you often missing? Do you feel unsupported or unsafe? Is anyone hurting you? Are you having troubles with drugs or alcohol? Is anyone in your family having trouble with drugs or alcohol? Do you hurt your body on purpose? In the past month, have you had thoughts about ending your life, wish you were dead, or wish you could go to sleep and never wake up? Do you have plans to hurt others? Has someone outside of your family told you that you need help with anxiety, depression, or behavioral issues? Have you been to the hospital to get help for mental health condition within the last 6 months? These are also weighted scores. You could see some are 2, some are 0. The number 15, are you having trouble with drugs or alcohol? Again, that's an automatic referral to our substance use program, and it doesn't affect the score of the behavioral health screening. However, the next question, is anyone in your family having trouble with drugs or alcohol? That absolutely would affect the youth, and so that is why that score has a number 1 to add to it. And then we have little directions here. So if the youth answers yes to 6, 7, or 8, completion of the screening evaluation should still occur. So we would still recommend for them to attend a full assessment. So 6, are you a foster care or child welfare services? 7, are you currently in juvenile hall? And 8, do you have housing or a safe place to sleep? So the state has said those questions are really important, and we really want to make sure that we serve those youth specifically. And then it goes on to say that 15 does not impact the mental health score, but it is a referral to our plan for a substance use evaluation. So those are the level of care tools. Those are the screening tools. They do not determine medical necessity, and they're not a reason for a client to be told you cannot seek care. It's more about a guide. Where would you better be fit? Medical necessity goes further. It really evaluates the client where they are, what impairments they might have, and what level of care they might need, which is done after a full assessment period. And so for beneficiaries 21 years of age or older, we must have at least a significant impairment, where impairment is defined as distress, disability, dysfunction in social, occupational, or other important activities, or a reasonable probability of significant deterioration in an important area of your life functioning. And then the beneficiary's condition, as described above, results in a diagnosed mental health disorder according to the criteria in the DSM-5, or a suspected mental health disorder that has not yet been diagnosed. The adult client meets criteria for specialty mental health services. What's next? So meeting criteria for specialty mental health services gets the client in the door. Medical necessity determines the level of care. And then we must say that services that sustain, support, improve, or make more tolerable a mental health condition are considered to make better the mental health condition and are thus medically necessary. So we have to make sure that all of the services that we do align with this philosophy. We can only do services that are medical necessary or will improve the client's condition. Youth are a little bit different. So as a youth, it doesn't take as much to meet criteria for care as it does for adults. And that is just aligned with the belief that if we catch it early, we can treat it and do better. And so that is why there's a big focus on early prevention, screening, and treatment and diagnostic services, which we refer to as EPSDT services. And those are usually more mild to moderate, and we do contract with the school district currently to provide that level of care. So for beneficiaries under the age of 21, the beneficiary has a condition placing them at risk for a mental health disorder due to experience of trauma evidenced by any of the following: scoring in the high risk range under a trauma screening tool, or involvement in the child welfare system, or juvenile justice involvement, or experiencing homelessness. This is criteria 1. Criteria 2, the beneficiary meets both of the following requirements in A and B below. So A, the beneficiary has at least one of the following: a significant impairment, a reasonable probability of significant deterioration in an important area of life functioning, a reasonable probability of not progressing developmentally as appropriate, a need for specialty mental health services regardless of the presence of an impairment that are not included with the mental health benefits that a Medi-Cal managed care plan is required to provide. So a little bit of context for that last one. That's a lot of language, but it's saying that a need for specialty mental health services regardless of presence of impairment. So if we can't identify an impairment, but we know they need specialty mental health services that they couldn't receive through their managed care plan or through a mild to moderate provider. We often have more services than what your mild to moderate provider can have at their disposal, such as case management support and group support and medications. So there's a little bit more that we can do than your average mild to moderate provider can do. And so sometimes a mild to moderate provider will say, yes, this client is in benefit of those services, even though we can't really determine the level of impairment that they're experiencing. And then B, the beneficiary's condition as described above is due to one of the following: a diagnosed mental health disorder from the DSM-5, or a suspected mental health disorder that has not yet been diagnosed, significant trauma placing the beneficiary at risk of a future mental health condition based on an assessment of a licensed mental health professional. So we really want to catch those kids that may have a budding problem happening just due to their life circumstances and history. The youth meet criteria for specialty mental health. What's next? So meeting criteria, again, gets you in the door. Medical necessity determines level of care. And youth are the same as adults in this way. We can screen and look at them, but all services must be determined to be medically necessary. And so they must have a service to them that supports, sustains, or improves or makes more tolerable their mental health condition. What does this all mean for actual practice? So this means more flexibility in completing assessment and determining a mental health diagnosis. We no longer need to rush a diagnosis, and no more included diagnosis list. We can use Z codes, unspecified, and other specified while we determine if there is a formal diagnosis. So CalAIM has made this lovely change where it says, before CalAIM, I should back up. Before CalAIM, we were on a very tight schedule. We had to make sure that every service was medically necessary. We had to make sure that every service fell underneath a formal DSM-5 diagnosis. Even the very first day that we met a client, we had to know a diagnosis from that moment forward to treat a client. We could use some of the unspecified codes to give us a little bit of assessment room, but we couldn't provide any formal service delivery outside of assessing and creating that diagnosis. And so it was very rigid, and it wasn't very whole person care. It didn't do a lot of service for clients. It really was paperwork and trying to get treatment established, which is really difficult when you're not on your best game because maybe you're having a mental health symptom day or maybe things are just really rough right now. And having to go through these steps and changes and be really formal about it was not really productive or helpful. So the state has stepped back and said, you know what, we're going to let that go through CalAIM. You're going to have authority and autonomy in how long it takes you to assess. You can provide services while you're assessing for treatment. And if at the end of treatment they don't meet criteria, we're not going to slap your wrist for that. It's okay. You did the best you could and you connected them to the right level of care. And that's all that matters. So now diagnoses can be a little bit more delayed and thoughtful. And so through our access clinic, instead of having the full assessment at that time, we're going to have case managers available to do those level of care screeners that we talked about earlier and come up with a Z code diagnosis, which are more psychosocial diagnoses, and they're more in line with like struggling with work or unable to get along with neighbor, at risk of homelessness. These things aren't formal DSM-F codes, but they are pretty important factors in determining mental health status and how one is feeling well or not. And so unlicensed providers have a list of Z codes. They're Z55 through Z65, and I will also include those in my handouts at the end that they can go through and see who might fall into those areas, and that will get them in the door. That gets you open to screening and service delivery, and then your clinician can take up to 60 days to land on a formal diagnosis. So frequently asked questions about access to specialty mental health services. Can I have a temporary unspecified or other specified or Z code forever? Or does my provider need to ultimately give me a formal diagnosis? So these codes can be utilized while the clinician takes their time to gather information about the individual's presenting needs and determine the most appropriate diagnosis and next steps, but they cannot be used indefinitely. So as a department, we have decided 60 days is the limit. That's a good chunk of time for assessment services. We are going to be flexible on those difficult to engage clients, or maybe the diagnosis is a little bit more unclear and needs a little bit more defining. But the burden will be to aim for 60 days. And then documentation and supervision will follow for those that weren't able to make it in the 60 days. So, however, in some limited, so that goes on to talk about how we might take a little bit more time with justification. I'm a complex client, and determining a diagnosis has taken my clinician more time than usual. I've also been receiving therapy, rehab services throughout the assessment process when I needed that. Is this okay? So yes, under CalAIM, we don't need to rush a diagnosis. The clinician can take their time to get to know the client and understand their needs, and they can provide clinically appropriate treatment services even though they are still assessing the client. This is a big shift for us because before we had to have our assessment completely tied up and our diagnosis set before we could do planned services, even planned therapy. So now we have the freedom to provide the care that the client needs. We can onboard case management immediately and get things started. We can do rehab group. We can enter them into anything that would benefit them. and then we can move forward with the assessment and see where that takes us. Before it was really complex, we would have to do the full assessment and then develop a treatment plan. And then the treatment plan would have to be reviewed and signed by the clinician, the supervisor, and the client, and sometimes the client's parent or guardian, and before we could actually call it formal and be able to utilize it. And then we have this thing called no wrong door. So no wrong door is a global mental health policy for the state of California, and it affects all levels of care, including primary care, to say that if a client comes into your office seeking treatment, you will provide services, screen them for the appropriate level of care, and connect them to where they need to be. Before, it would be, you would come into us, we would say, we did the full assessment, it looks like you are not our level of care, please go find that level of care and good luck. Or maybe your primary care doctor would say, well, I could send a referral, but once I send the referral, I'm not going to follow up and see if they actually got it or followed up on it. But you can call them yourself and make it work. So through no wrong door, that goes away. Now everyone has the burden to make sure that a client who is seeking care is connected to some level of care. So what is no wrong door? It ensures that Medi-Cal beneficiaries receive timely mental health services without delay, regardless of the delivery system where they seek care. That beneficiaries are able to maintain treatment relationships with trusted providers without interruption. Having both managed care plans, and for us in Plumas County, that's California Health and Wellness, or Anthem, and then our MHPs, which is Mental Health Plan or Plumas County Behavioral Health, use the same screening and transition tools to allow for a streamline of beneficiaries' access to services. So behind the scenes for the last year and a half, I have been working with California Health and Wellness and Anthem to develop MOUs that allows data sharing between us so that they can send over information for one of their beneficiaries that screens higher than their level of care, and I can send them information about beneficiaries that screen too low for my level of care. And now there is this obligation where not only do we share that information, but we communicate that we've initiated care or has onboarded services so that we know that you are connected to care at the end of the day and that you don't have to seek it yourself or wait for somebody to get around to calling you back. And then we also have the ability to maintain treatment relationships. So if you are served at a more mild to moderate provider, maybe True North in the community, you're seeing one of their providers, and they say, they really screen in a bit higher and could use more service delivery than what we're able to do, such as case management or rehab, they can then seek out our services to support their services so that you can continue with your True North provider, but still receive case management, rehab, and medication support through my service delivery. Before, it was very siloed. You either seek care with me or you seek care with them. We cannot share. You have to pick one. And so this is a benefit for the community as a whole. It will allow us to work more together as providers, but it will also maintain treatment relationships and avoid the bouncing back in between that sometimes happens when clients go between levels of care or dip in their symptoms, or how it goes around here. So what does this mean for actual practice? It promises improved coordination with other systems. So it's easier to add services across systems. A client can be seen simultaneously in multiple systems if clinically appropriate and not duplicative. So again, we go back to where I can't duplicate care. If you are getting individual therapy from True North, I cannot give you individual therapy over here at Behavioral Health. We must support services, but not duplicate. And that's just to make sure that we're not treating for different things or in different ways that might be counterintuitive to each other. More opportunities for integrated care. A client with a co-occurring diagnosis does not have to choose between one system or another. So this PowerPoint was really developed off of a lot of state information and guidelines and things of that nature, where a lot of times in California, they are not an integrated SUD and behavioral health department. Sometimes they're separate, and sometimes they contract out for those services. But here in Plumas County, we are both. So this doesn't really apply to us because we are already integrated with co-occurring diagnoses. But it's good information to know for the other counties, or if we in the future are able to contract for our drug Medi-Cal services. It would mean that we could share information and co-treat you together. So while there are still some regulations that DHCS is trying to work out to further integrate, this is the direction that we are moving to. A lot of people, when I talk about integrating care between co-occurring diagnoses and other practitioners, The concern is around privacy and HIPAA. And so they're really working that out and trying to see how they can better integrate and share information without stepping on HIPAA or CFR 42. So frequently asked questions about no wrong door. I thought no wrong door meant that the client must be served in whatever program they showed up to. Nope. While the goal is to get the client to the services as seamlessly and quick as possible, no wrong door does not mean that the client must be seen in any program. If an adult client shows up at a youth program requesting services, the youth program would not treat this client. No wrong door is referring to the system, not the program. So system means managed care plans or Plumas County Behavioral Health. So it doesn't mean that you get any program you want or show up to. It means you get the level of care or the program services that we're able to provide that are appropriate for you. So instead, we would connect the client to care. For example, the Access Call Center, we have screening tools and referrals that we can send over to our managed care plans, and then they could help connect us to one of their providers. Does this mean that the client can have more than one individual therapist? Again, this is not true. We must honor the non-duplicative services. So as long as the services are coordinated, clinically appropriate, and not duplicative, we can share a client. If the client has an established relationship with a provider from one delivery system, they can continue working with that provider, even if they meet criteria for a higher or lower level of care. They can receive services concurrently from both systems as long as they are clinically appropriate and not duplicative. The other piece of this is clinically appropriate. So if you are at a lower level of care and you need a higher level of care, there could be a limit to what that lower level of care provider is able or comfortable to treat. And so if you start to have a more higher acuity or a greater need than what that provider can take on, they may recommend that you just switch to one of our providers and no longer seek care through them. And that is their decision, not a system decision. And so we would just work with you and that provider to try to work it out as best we could. But there will be times where that doesn't work all the time. The emphasis is supposed to be on honoring client choice. So we want to make sure that we meet our clients where they are most comfortable and where they have the most opportunity to succeed. So this is an example of a potential PCBH client named Ty and how no wrong door would work. So Ty is 30 years old, has a managed care plan therapist who believes that Ty requires additional services that PCBH can provide. So they would do a transition tool that determines that Ty meets access criteria for specialty mental health. The clinic begins assessment, our clinic. Assessment determines that Ty would benefit from therapy, case management, rehab, and med support. So clinician updates problem list with diagnosis, completes appropriate treatment plan requirements. Ty requests to be able to continue to see his managed care plan therapist due to a long established care. Ty continues to see the managed care provider therapist for individual therapy and begins seeing PCBH staff for case management, rehab, and med support. I accidentally skipped a couple of steps here in the middle, but it just talks about that Ty's presentation is complicated and requires rehab support, even though they're not done assessing. And so he can go ahead and onboard those services while they assess and then determine level of care. If Ty had required rehab support and case management support, and then at the end of assessment was determined not to meet that level of care requirement, it would be okay. We wouldn't need to worry about those services already rendered. The state will honor the claims and pay them. It would just be our obligation to document our attempts to assess and recommend an appropriate level of care. So I'm going to take a moment. There's only one person live here. Denise, do you have any questions so far?
No, I think you're doing a great job, Jessica. Thank you.
Awesome. All right. We'll plug forward. So now I want to talk about our problem list. It is a new thing in the client's chart, and I think it's important to talk about. So the problem list is something that is here to replace our old previous diagnosis review form. Most of these things are very system and behind the scenes, but beneficiaries and clients always have the right to request a copy of their clinical chart information. And so these things do come out in those sorts of requests. And so it's important to know what they are and how they function and how we use them, because that's going to be a big deal going forward. So problem list applies to my mental health plan and my drug Medi-Cal clinic here. The problem list requirements. The problem list is a list of symptoms, conditions, diagnoses, and risk factors identified through assessment, psychiatric diagnostic evaluation, crisis encounters, or other types of service encounters. So, what kind of concerns are you having that brings you to our service delivery? It's a problem that is identified during a service encounter, may be addressed by the service provider within their scope during that service encounter, and then added to the problem list later. So previously, going backwards before Cal-AIM, if we identified an issue for a client that was not on their diagnosis form or their treatment plan, we would have to put it on a shelf and pin it for later. We would say, I'm sorry, I can't deal with that today. That's not on your treatment plan. It's not on your diagnosis form. We're going to have to wait for your clinician to add that later. And then you're going to have to agree to your treatment plan and re-sign before we can work on it. So if somebody comes in crisis, I just got an eviction notice. I don't know what I'm going to do. I need help finding new housing. It's super urgent, but I'm sorry, that's not on your problem list. We're going to have to wait that out. Through Cal-AIM, that's not the case anymore. Right now, they say you come in, you have a presenting concern, just like your doctor's office. When you come in with a sore throat or an achy back, we're going to treat you then and there for it. We're not going to wait for another clinician to evaluate you and add it to your problem list and your treatment plan. And so this means we get services going almost immediately, which is, of course, very helpful and calming. So now a problem can be identified by our case managers instead of a licensed professional, as long as they're within their scope. So the Z codes that we talked about earlier, and then they can be treated at that time. And even if they don't have time to add it to your problem list at that moment, we can add it later and document the need for it retroactively, and the state will still say that's okay. When before, if they found a single claim that was not included on the treatment plan, it would be disallowed and we would have to give that money back. And the provider shall add or end date problem lists from the problems from the problem list when there is a relevant change to a beneficiary's condition. So the problem list doesn't have to be done at a certain interval, but it should be added or updated as things change for the client. Before, our treatment plans were pretty static for about a year. They would span a year and we could revise them and make changes to them, but it was pretty cumbersome and burdensome and it wasn't very fluid. And so it was very reluctant to make those changes as frequently as they could probably be made. So I'm hopeful that the problem list being a more simplistic effort will be more fluid and more real time for clients. So mental health and substance use diagnoses used to live on our diagnosis review form, and now they're moving to the problem list, which will hold mental health diagnoses, substance use diagnoses, social determinants of health needs, those Z codes. There's other Z codes as well, and then physical health conditions as well. So the hope through this new push through California called interoperability, that we will share problem lists across service deliveries. So your primary care provider has a problem list as well. And eventually the expectation is that their problem list lives with my problem list. And so that we can see the problem lists between each other live in real time. And my chart would include your physical health conditions and their chart would include your mental health conditions. Obviously, this is a really great wraparound idea for care, but there comes a lot of concerns about privacy and data information sharing. And that's the part they haven't quite finessed out, and how that's going to work and live happily. But California has mandated this for the mild to moderate populations, and so they're already sharing problem lists in that way. And now they have to figure out how they're going to expand that to specialty mental health services and get us into it as well. So what is included in a problem list? The problem list shall include, but is not limited to, and this is kind of a repeat slide, we just kind of talked about it, but it must have the diagnosis identified by the provider acting within their scope. Problems identified by providers acting within their scope of practice, if any. And then problems or illnesses identified by the beneficiary or significant support person, if any. So if you or your spouse or your mom or your minister, your best friend have some concerns that they want to bring up, this is enough of a problem for us to list on a formal problems list. They would still have to be within scope. So you can't come to me and say, oh, I've had schizophrenia for years, but I don't have any medical records to support it. I can't add that to the problem list at that time without doing full assessment and determining that through a clinical evaluation. However, if you have an outside provider or previous treatment provider that has made that diagnostic impression, you could bring those records in and we could add it to our problem list as an external source. And so now we can see, hey, this person was evaluated by a psychiatrist through PDH. We have that documentation. We can see the diagnosis that was given at that time. We can add it to our chart as a historical diagnosis. And that way we have more information available and it paints a better picture of what's truly going on for the client. The problem list shall be updated on an ongoing basis to reflect the current presentation of the beneficiary. So again, we used to update our diagnosis forms anytime we did assessment or an update to the treatment plan, but it was typically annually unless something came up urgently in between. This will allow more fluid adding or removing from the problem list so that we can be more accurate with treatment and progress. DHCS does not require the problem list to be updated within a specific time frame, so they've allowed the counties to make that decision. However, providers shall update the problem list with a reasonable time and in accordance with generally accepted standards of practice. So we do want to be in line with what is expected of us and what makes clinical sense. So we are still going to hold that at least annual process, but we often want to see it more frequently, especially as we transition through care. So in California, there are multiple statewide and local efforts to drive information sharing and to facilitate improved outcomes. The problem list is part of that data interoperability set nationally. So it's not just a California thing, it's a national thing that we're doing, sharing information in live time. And as we implement the problem list in behavioral health, we will both send our information to others in the client's healthcare team and receive information in our electronic health records. So right now, where we're at with this process is that we have signed data sharing agreements, and they've gone through the Board of Supervisors here in Plumas County to be approved for California Health and Wellness and Anthem. As it operates right now, the only data that we are sharing is the beneficiaries that we serve versus the beneficiaries they serve. And then if one of our clients or a Plumas County Medi-Cal beneficiary ended up in an emergency room, they would be screened for behavioral health symptoms, including SUD. And then if any of those things were endorsed, they would send me a little notification and information for me to get in touch with that beneficiary to try to link them to care. And we're still in the really, really early stages of that. We just got the agreement signed. And so now we're starting to develop how we're going to push data back and forth. But eventually they hope to be more streamlined, more live time, and more detailed into the actual problems instead of just, hey, this person meets criteria for you, please come find them. And so the hope is that by sharing this information, we cut out the barriers to care and we get people quicker than if we wait and try to chase them and do referrals and shuffle paperwork back and forth. And then there's a topic about no more treatment plans. So if you've ever been in my service delivery or you've had a significant loved one in your life go through my service delivery, chances are you've had to participate in treatment planning. A treatment plan would talk about your strengths, your problems, your goals, how we're going to get you to your goals, and what services would get you there, and what it looks like when you get there. And so they were very detailed, very, very detailed, and it would require a bunch of signatures, as I talked about before. And they were pretty burdensome and not updated as frequently as what would be helpful. And so the state has said, no more treatment plans. We're not going to deal with that anymore. Everybody said they were super difficult to work with and they were very static and not very client-centered. And so do away with them. So it's true, most of all of our treatment plans are going away. Instead, it will be up to the clinician and the client's progress through treatment that will determine length of care and fluid goals to work on. So we're no longer authorizing 12 months, 6 months, 9 months. We're not saying the clinician has a limited amount of time to treat you and get you out the door. We're now saying it's up to the clinician and the client. You treat them as they need to be treated and then identify when they're ready for a step down in care, and then we'll link them to that lower level of care, connect them, make sure they're connected, and then release as a positive or a successful discharge. And that will be guided through outcome tools that we're developing. And then California is set to release that transition tool that we talked about, which would also identify clients that were ready for a step down in care. Now, I said most treatment plans are going away. There are some situations that we have to keep a treatment plan, but it's going to look a little different. So for our targeted case management services or those linking support services, maybe I have a client that needs help getting connected to Medi-Cal, or maybe they need some CalFresh, or they need housing assistance, or maybe they need employment assistance, or they'd like to go back to school. There's a lot of things that clients need support getting connected to because there's so many different systems, and accessing those systems can be really overwhelming, confusing, and difficult to navigate if you don't have a supporting hand that's skilled in that. And so that's where our staff can come in. Targeted case management services gets you linked to other support services that you need in your life. That has to be on a mini treatment plan. And then our peer support services, these are guided by the state. And so those have to be really specific. And so a little mini treatment plan to guide those service delivery will be necessary, as well as our substance use services. Those are guided by Title 22, and they will remain with a mini treatment plan that talks about services and frequency and how they can best suit the client's needs. These are now going to be treatment plans in the form of a progress note. So instead of doing a really bulky treatment plan that has all these little requirements and signatures and all that fun stuff, our providers are able to just write a progress note that talks about the need for the service and what it looks like when the service is no longer needed. So I had a client come in today. We'll call her Sally. Sally comes in and says that she would really like to get full-time work so that she can support her family and make it better in the world. And so I would say, Sally is in need of employment services, and I will connect her to the Allied for Workforce Development Center. We will research openings in the community. I will show her how to develop a resume and apply. And these services will no longer be needed once Sally is able to gain full-time employment. And that is the end of the treatment plan. Nobody has to sign it except for the provider, and it is done. The other nice thing about AIM is says that treatment plan can come after the service. So if Sally comes in and says, I need to be connected to employment services, I said, all right, let's go over to Alliance for Workforce today. I know they have an open house. We can look at all their job openings. Let's go. Get in the car and drive over. And then when I come back to the office, maybe 2 days from now, I can go back and write that progress note that talks about Sally needing employment services and how I'm going to connect her to that care and what it looks like when I'm done. And so it comes after the service, but the state is not going to audit me and take that away from me now. They say, that's okay. You did that in good faith. We understand the need to act on it now. So go ahead and continue to do that work. It's all good. The other need for a treatment plan, and this is a federal required treatment plan, and so it has to be the old formal, very bulky treatment plan, is for our intensive youth services, such as in-home based services and intense care coordination. This will still be really formal with all the signatures and the interventions and goals and all of the narrative that goes into them, but it will be limited to only those two services, so IHBS and ICC. And those are usually reserved for our foster youth who are at risk of losing placement due to behavioral health concerns. And so it's really important that those are done to the best and through very careful consideration. So I really don't mind that those have to be a formal treatment plan. I think it's in the best interest of the youth. And it's only 2 service deliveries that we would have to develop the plan for. And then all the other services could be conducted just like everybody else. Any questions about treatment plans or how we're going to give care?
No, thank you.
Okay. The other little thing of AIM is that we're doing some documentation changes. And the state has said less is more. And we completely agree and cheer because documentation has been an extreme burden for our clinicians. So the state has done some studies. They've listened to the counties and they've come up with the idea that staff could complete 6 to 10 more services per day if they had less documentation requirements. So in many electronic health records, each note takes 15 to 20 minutes to complete. Those staff may or may not bill for all of this time. Oftentimes staff feel like they are taking too long with their notes and it's not reasonable for them to actually put 20 minutes when they only wrote a little bit. But a lot of times they're sitting there struggling to find the words because they want to be accurate with their documentation. But also the state had required that our progress notes had very rigid language in them every single time. So every single note would have to state this service meets medical necessity requirements. I am treating this formal diagnosis. This is how the problem or the client responded. This is the intervention I provided, and this is the plan for next time. And so those are very detailed, very rigid requirements, and staff would really agonize over that. And they would sit and they would think, how can I make my note make sense and make sure that Medi-Cal is going to approve it? I really don't want an audit or a disallowance. Oh, this is so hard. And so at the end, they would only write what they could think would meet the requirements. And then they would only claim a little bit of that time because they felt guilty for the actual amount of time it did take them to write the note. And so then we weren't honest with our claiming. And so we were spending more time than what we were reporting. And then reducing clicks. So now they're saying progress notes don't have to be from scratch, handwritten. They can be narrative boxes. We can have some pre-fill options to help reduce staff time and writing notes, as long as they're not copy carbon pasted from other services. So they still have to be unique in the narrative, but we can take some shortcuts to help fill that in. And they believe that 8 notes in 20 minutes equals 160 minutes of note writing. So we could be saving nearly 3 hours, which I completely agree. It's wonderful that they've made this change. They really want us to shift our focus of progress notes. So before, our focus was really about reimbursement, which is the last wing of this little 3 cycle here, and audit protection. We're really worried about the audits. They only happen every 3 years. And so it's a possibility that we could be doing something wrong for 3 years. The state could come in and find it and take all the money back for all the services for the last 3 years. And so a lot of anxiety went into note writing, a lot of review and careful auditing would go through documentation. But they want us to shift that focus. The state is saying we are no longer going to audit you on your documentation. We are only going to audit for fraud, waste, and abuse. If you don't show any signs of being fraudulent, wasteful, or abusive with your care, you're not going to have an audit finding or a recoupment. The worst that it will be a plan of correction, where we'll tell you, hey, you could do this better next time. And then you would make a plan on how you're going to train staff to make it better and when you're going to do that by, and let us know when it's done. And so it's a lot less of a punitive process, and it's more in line with the new philosophy that notes should be written to help communicate information. We want to talk about care planning. We want to communicate the status of a client or a service to the client to the next provider, so that when the next provider comes into the chart, they can pick up that note and understand what you were working on and what the next steps are. And then, of course, we do want to be reimbursed because we do have to, have money to operate. And so every service delivery must have a progress note attached for it to go to the Medi-Cal claiming system. And so we want to make sure that we're doing that at the very limited structure that they've come up with. So going on into it, 3 key functions of progress note is care planning, used as a basis for planning treatment among practitioners and across programs. Should be understandable when read independent of other progress notes. So should not say, hey, see other note or see other assessment for more information. Should provide an accurate picture of the treatment provided and plan for future care. And communication, used to communicate with other care providers. Provide a quick exchange of information to coordinate care, reduce duplication of services, and improve outcome. Should reflect what is up next and what is needed. And then, of course, we must use it to have a verification for services and get reimbursement, and our legal record to describe treatment provided, and must include sufficient documentation of the intervention to justify payment. So we have to talk about what service we provided and how that benefited the client and what our plan is for next time. Another little wing of interoperability that I skipped over earlier is the idea that we need to operate with a client portal, which will give live, real access to clients to their clinical record. We're not ready for that yet. Our EHR system was purchased and implemented in 2011, so it's a little outdated and not able to keep up with these regulations as they change. But we have already purchased and we're ready to onboard a new EHR, and we're hoping to bring that on board by next summer. And that EHR will have client portal access to it. And so the idea is that we can be more brief and to the point with our documentation and be more clear and transparent instead of really worrying about audit protection and using all those fancy words and acronyms to make sure that we get our claim paid to be more basic and easily read, so that when clients get into their record, they don't have to guess what the language is trying to say about them. It's very easy to read, it's understandable, we know what treatment was provided and what the goal of the treatment was. So the problem: long progress notes due to fear of audit findings. Need to establish medical necessity in every note leads to overwriting by staff, and notes so long that are not read by others and key information is lost. So the real emphasis on CalAIM is sharing information and collaborating with other providers and not being wasteful. So if we have our staff documenting notes, then another provider should be able to pick up that note and understand the services that were provided without having to go through a very in-depth conversation with that provider to go over the service delivery. So that it reduces the amount of time spent trying to gain history of the client and the treatment that they were provided. The new policy is fewer progress note requirements. It is most crucial to record the service and interventions provided and plan for next steps. And then impact. Less time spent on documentation means more time spent with individuals who need services. And then we also have fewer audit disallowances so that we have less money taken away from us. So progress notes must have these components. They must have the type of service rendered. So we must say what kind of service we provided: individual therapy, collateral, plan development, assessment, it goes on. A narrative describing the service, including how the service addressed the beneficiary's behavioral health need. So what did I do to help the client today, and why did they need that? The date that the service was provided, the duration of service, the location that the service was provided, and next steps, including but not limited to planned actions steps by the provider or by the beneficiary, and collaboration with the beneficiary. So this is what we did today. This is what you're going to do for next time. This is what I'm going to do before next time. And then we'll meet on this date. And they really want us to be person-centered. A person is not their illness. Person-centered language emphasizes the person first rather than the illness. So we want to say, we want to be positive with our words, not the schizophrenic client, but the person who has schizophrenia. So people are so much more than their substance use disorder, mental illness, or disability. Using person-centered language is about respecting the dignity, worth, unique qualities, and strengths of every individual. A person's identity and self-image are closely linked to the words used to describe them. We've known this for years, and we've operated on that belief, and we try our best to meet everybody where they're at. It's really refreshing to see the state take this stance and to be more focused on it. And I'm hopeful that it means that they're going to be a little bit more aware of how we operate and the things that we need to do to meet our clients. Of course, a lot of people will point out, we really like to tout about person-centered language. The person is not their illness. And then the state says we must move to a problem list, which just describes a person's problems. So there's little baby steps happening. Obviously, we need bigger changes to come. But that's not something I can affect change on. The problem list was set by the state to match the medical provider's use of the problem list. So I don't see that changing its term anytime soon, but I do acknowledge that it is counterintuitive to this. All right. So this is my last slide for questions about anything that's come up during this training, or anything at all, if you have any, Denise.
Well, I do have a few. So just for clarification for me, when you were talking about managed care providers, I know that behavioral health is Medi-Cal. So is managed care mean private insurance and lower, the mild to moderate of Medi-Cal population? Or, when you were talking about the two different providers anyway, between behavioral health and the managed care providers?
Absolutely. So the managed care providers are, when one signs up for Medi-Cal nowadays, you have to choose a plan. You can choose California Health and Wellness, or you can choose Anthem. They're both Medi-Cal plans, but those are the two choices to choose from. Specialty mental health services have always been a carve out. And so when you're SMI or our level of care, we don't really care which network you are with, California Health and Wellness or Anthem. That makes no difference to us because we bill the state directly. But the mild to moderate providers, Michael Gunter is one, True North is one, they contract with those networks. So they have a contract for Anthem Medi-Cal, or they have a contract for California Health and Wellness Medi-Cal. And then there's other commercial plans, not California Health and Wellness, because that was truly developed for Medi-Cal. But Anthem has a commercial line through like SPI or Operating Engineers where they will cover us, but it's not Medi-Cal. It's business commercial. So it's a describing network of insurance. And most Medi-Cal people have a card. So if you pull out your card, it should say at the top which one it is. And then there's a very, very small population in the county that doesn't have either. And I think it's very hard to find those folks these days because the county has really pushed choosing a plan. You have to pick one. And then because if you don't have access to as many services. When they contracted with California Health and Wellness and Anthem, they contracted for a set of service delivery, different things. And the managed care plans are now obligated to do what is called enhanced care management, which is a version of case management that you would typically get through us, but it's more formal and over the phone. Through CalAIM, there's been a push to make that a requirement in person. And so EA, for example, has signed up to be an enhanced care provider, not through behavioral health. So even though they are a specialty mental health contracted wrap program for me, they went further and contracted with Anthem to do enhanced care management separate from us. So they would do case management type services like we do, but for the mild to moderate population. And that way, it kind of takes a little bit of the burden off of us, and it enhances care for everyone. Because before, if you needed case management, you had to be specialty mental health. You couldn't get that anywhere else. And so now EA and I think public health has signed on to be an enhanced care provider, but it's a little bit different.
Thank you.
Yeah.
And then the term no wrong door, that's been around for a while, right? So it's just a new use of that no wrong door?
Yes, they went further to define it because when they initiated it originally, it was a little messy and it wasn't as structured as they were liked, and they weren't getting the same outcomes that they were hoping for. I think we tried it through a whole person care pilot for a little bit, and that didn't really successfully take off here in Plumas County. And I hear other counties struggled with it as well. And so they just redefined it, gave us more guidance, and then they required us to turn in policy and procedure to support it so that we understood and they understood that we understood.
Okay, okay. And then the PDFs that you said will be available, will that be the problem list, the screening tool, and the Z codes, or is there some other things that will be available, online or through this recording?
So I have the PowerPoint that we did today. I have the screening tools. The problem list, I can give you the documentation guide that the state issued for us as well. And it has samples of the problem list inside of it. But the problem list is a living document per client. So I don't really have one that I could share. But there are some samples out there within the documentation that we could give.
Yeah, I'm curious as far as the physical things that would be listed and the mental health stuff. So I would like that.
Absolutely.
And then I love the change of the care plans and having fluid goals and not having to, graduate within a certain period of time. I think that's a good change and less burdensome for you guys, like you say. So thank you.
Yeah, of
That's it.
course. It's a lot of
That's all
work.
my questions.
Okay. Well, thank you. I'm going to go ahead and end the recording. Oops. Maybe.